Hello, I'm Dr. Richard Usatine. I am a professor of family and community medicine and a professor of dermatology and cutaneous surgery. I am the founding director of the University Skin Clinic, and I work and teach at the University of Texas Health in San Antonio. And we're going to be talking about acne today. So here's my disclosure statement. I don't actually have any conflicts of interest, but I am going to disclose that I am an editor for a Journal of Family Practice and a editor for the Visual DX, one of many editors. And I am the author of 10 medical books, including the lead author of 8 of those. And I do have a app development company. So those are my disclosures. And the images are basically mine unless otherwise indicated. So our objectives today are to understand the proposed etiology of acne vulgaris, to utilize appropriate criteria to diagnose acne as mild, moderate, or severe, and to formulate treatment plans for acne and modify therapies as necessary to minimize adverse side effects and maximize benefit. Okay, so what's new in the realm of acne? Well, there is a new topical anti-androgen. There's a new topical antibiotic, which is an old antibiotic, minocycline, now in foam. That makes it new. And there is an oral antibiotic that is new, and it's a type of tetracycline called sarecycline. So we're going to talk about the new, but we have to talk about the old first. And so what's old? Well, the steps in acne pathogenesis haven't changed, as far as I know, since the dawn of humankind. And what happens is that we have the obstruction of sebaceous follicles with sebum and desquamated cells. We have a disruption of the follicle wall, and then the extrusion of bacteria, sebum, hair, and cells into the dermis, causing inflammation. Now, what's new on this slide is that we used to call the bacteria Propionum bacterium acnes, but now we call it Cutibacterium acnes. And if you're having trouble remembering that name, because someone might ask it on a board exam, just remember it's kind of cute. It's Cutibacterium acnes. And it doesn't cause an infection, it causes an inflammation. So the pathophysiologic features are sebum overproduction, abnormal desquamation of the follicular epithelium, which causes keratin plugging, the Cutibacterium acnes, which proliferates, and the inflammation process that occurs. So we've got to basically aim our treatment at these pathophysiological features. But we also need to understand the lesions that we're looking at. So we want to recognize that closed comedones are whiteheads and open comedones are blackheads, because when they're open, we get oxidation and they become black. They're inflammatory lesions that are papules and pustules, the smaller ones, and nodules and cysts, the larger ones. And we call them cysts, but they really are just deep inflammatory nodules. They're referred to as cysts. They're not true epithelial cysts with a cyst wall. You don't cut it out to try and excise the cyst wall, because there won't be. It's just inflamed. So let's talk about causes and exacerbating factors. The biggest one is genetics, and obviously we can't affect that, at least not now. Androgens play a large role, and the hormonal studies are not needed unless there are other signs of androgen excess. So it's just sometimes it's a hypersensitivity to the androgens in the skin that allows the acne to occur. It may not be an androgen excess. Stress makes it worse. And diet. Does diet make it worse? Well, that's a good question. And we're going to refer to these guidelines throughout the talk because these are the most recent guidelines for the management of acne from 2016, published by the Journal of the American Academy of Dermatology. The lead author is a friend, Andrea, and I had the opportunity to teach with her, which is wonderful. I get to hear her lecture on acne. So what is the evidence when it comes to diet and acne? Well, one is that milk, and actually just excessive skim milk intake, may increase acne in teenage boys and girls. There were these two studies. Many people find the studies are somewhat flawed, but I don't have many people or teenagers or adults that are drinking large amounts of skim milk. And I've yet to find someone who is doing that, and that is the cause of their acne. So you can ask, but don't expect a lot of bang for that buck. Do chocolate and fried food have an effect on acne? Probably not. The evidence is just not good. And does a high glycemic index food make it worse? Well, maybe, but it's not conclusive. So I move on from diet. I don't really spend any time on it unless people ask questions about the diet and its relationship. It might be the mom saying, trying to get the child to not eat so many French fries that are greasy. But, kids, adolescents, they like French fries, but they're getting their acne probably not because of the French fries. Obstructive versus inflammatory. So we'd like to know whether it's mostly obstructive or inflammatory. We'd like to know, is it mild, moderate, or severe? And this helps us to decide upon the therapeutic approach. Now, I showed you the obstructive lesions, which are comedones, and most everything else is inflammatory.